Welcome back. You've mastered the technique of acquiring the parasternal views, and now it's time to put them to work. This isn't about subtle measurements, it's about answering one critical question when your patient is crashing. Is there a life-threatening problem I can't see right now? Let's learn to spot red flags from just one window, the parasternal window. Here is our first case, a patient who arrives in the NE breathless, with borderline blood pressure. You've got the machine, you've done your clinical assessment, and now you are looking at your parasternal view. From the far field, you can see that there's no pericardial effusion. As you focus on the heart-focused views, you notice a marked reduction in wall thickening and inward motion, especially in the infralateral wall. That's a clear sign of regional wall motion abnormalities. When you add color on the aortic valve, not much regurgitation. And when you add color box on the mitral valve, there is some mitral regurgitation show up. But it's not significant enough to explain the acute deterioration. Then, as you rotate to your short axis views, you confirm that the aortic valve opens and closes well, and there is no significant stenosis. But you can see that the right ventricle is not contracting well as well in this view. When you tilt down to the mitral valve level, you can see that the mitral valve is with normal structure. There is no much concern about the mitral valve in this case. But again, you can see clearly that there is marked regional wall motion abnormalities. You see a striking abnormality here, almost akinesis, with some brightness, likely scarring in the inferior walls. This is the RCA territory. The other walls aren't moving well either, and there is some dyssynchrony. When you move to the mid-level, you can still see that there is global reduction in contractility, but still predominant in the RCA territory. To the apical view, as you can see, there is still reduction in the overall contractility with hypokinesis. So, what's the overall impression? There is no pericardial effusion or major valvular dysfunction. The big red flag here is severe LV dysfunction, all revealed from the parasternal window. That's your first crucial clue from this view. And here's a quick pro tip. Always train your eye to notice both wall thickening and endocardial motion, as well as a synchronization of all walls. In a healthy heart, the walls visibly thicken in systole as they move inward. If you are not seeing that combination of thickening and inward motion clearly, then you know that the squeeze is weak. This is the power of training your eye through visual assessment. Over time, in emergency setting, this skill becomes second nature. It's not just about recognizing subtle hints, it's about quickly identifying those key visual cues that tell you exactly what's going on. In this next case, we have another patient presenting with breathlessness and borderline blood pressure. Once again, you do your clinical assessment, you bring out your echo machine, and you start with the parasternal long axis view. There is no pericardial effusion here either, but what stands out right away is that the right ventricle looks dilated and hypocontractile. Something is clearly going on there. When you rotate to the short axis view, it becomes very obvious that the septum isn't moving normally. In a healthy LV, you would see a perfectly circular ventricle with a well-synchronized septum. But in this clip, the right side is dilated, the contractility is impaired, and the interventricular septum is flattened, making the LV look like a D shape. That's a crucial sign of RV pressure overload. Think about conditions like a massive pulmonary embolism or severe pulmonary hypertension. The RV is working so hard that's actually deforming the LV. In a shocked patient, your first thought should be a massive pulmonary embolism. Also consider the timing of the septal flattening. If it's mainly systole, think pressure overload like pulmonary embolism or pulmonary hypertension. If it's diastolic, think volume overload like severe tricuspid regurgitation or a significant shunt. So that's another red flag identified from a single window, showing how the echo can make a huge difference in managing two patients with the same presentation but completely different underlying causes. Alright, here is our final red flag. In this last case, we have yet another patient presenting with breathlessness and borderline blood pressure. From your parasternal long axis view, you immediately notice that there is an echo-free space around the heart. There is fluid both anteriorly and posteriorly. And you see that it is circumferential, sitting just anterior to the descending aorta. This is your landmark. That's a very clear sign of pericardial effusion. Now, the size of the effusion is a warning sign, but remember, size alone doesn't tell the whole story, and the speed of accumulation is really important. The real red flag is the hemodynamic effect, whether we are seeing signs of tamponade. In this case, you might see subtle hint of RV diastolic collapse, but to be sure, you need to study this patient more comprehensively through apical window and subcostal windows. That's where the apical four-chamber view comes in. That view helps you assess all four chambers, quantify function, and confirm life-threatening emergencies like tamponade by clearly showing diastolic collapse of the RV free wall. So, how do we master that apical window to get that crucial view? That's exactly what Module 3 is all about. And just to emphasize, these are simple hints for the red flags you can identify through your parasternal window. We are still in our foundational modules mastering these basic views and how to get the views. In the future, we will have dedicated lessons that dive deeper into red flags and emergencies. For now, we have got a strong foundation. Let's move on to Module 3 and unlock the power of the apical views. See you there.